Thanks, Geordie. And thanks to the conference organisers for this very kind invitation for me to present the results of the CHOSEN trial on behalf of the CHOSEN investigators.
You're welcome.
So these are my disclosures. So starting off with pneumonia complicating stroke. So pneumonia occurs in around 9 to 14% of people that are hospitalized with a stroke. And there are several key things that we need to consider. The first is that pneumonia is consistently and independently associated with adverse clinical outcomes. So you can see here there are two plots. Can everyone see the little mouse on there? So this here is from our national SNAP data, and it shows the distribution of modified Rankin scores for those people that had pneumonia in the first week compared to those that didn't. And what you can see in the group that had pneumonia, mortality was about 40%. And actually, if you look at mortality and severe disability, we're talking about 60%, and that is compared to around 20%-ish with severe disability and mortality without pneumonia. So pneumonia occurs most commonly in the first 7 days after stroke, and this is called stroke-associated pneumonia. And in particular, pneumonia occurs within the first 24 to 48 hours after stroke onset. Oop. So there are a number of modifiable and non-modifiable risk factors that have been identified for stroke-associated pneumonia. And what I want to really talk about today, the whole basis, is that if we can identify modifiable risk factors for pneumonia, for example, dysphagia, then perhaps these can be targets for preventative interventions that can reduce the likelihood of people developing pneumonia and therefore increase outcomes. So this slide just gives you an overview of what we think is the current pathophysiological paradigm for the development of stroke-associated pneumonia. So in general, to develop pneumonia, you need a reservoir of infectious organisms, you need a portal of entry for them to get into the lungs, and then they need to overcome host immunity to cause pneumonia. So in the setting of acute stroke, we have all of those things. So stroke will disrupt the normal oral flora that occurs in the mouth. So there are hundreds, if not thousands, of different species of microorganisms living in some degree of harmony, but with certain species causing gum and periodontal disease. After a stroke, this balance actually shifts, and the proportion of more nasty pathogenic species increases. And of course, we all know that after an acute stroke, people are at risk of aspiration, and this serves then as a means of these organisms and the debris associated with them getting into the lungs. And not only that, but people after an acute stroke are actually immune suppressed transiently, which means that they are in increased risk of developing infections. So perhaps oral health care could be a strategy if we can reduce oral bioburden in the mouth. This could be a way of preventing pneumonia from developing and therefore improving outcomes. So what do we know about how to deliver oral health care to people that have had a stroke? And I'm afraid to say not really very much, actually. So for community-dwelling adults that look after themselves, it's fairly straightforward. The recommendations are that you brush your teeth twice a day with fluoridated toothpaste. And we also know that if you want to improve gum disease and periodontal disease, then chlorhexidine, which is an antiseptic gel, and powered brushing are far more effective at doing that. So if you think about a patient with a stroke and their journey from the acute phase through to back into life after stroke, then the types of approaches for oral health care may need to differ depending on what we're trying to achieve. However, my argument has always been that in the initial phase of stroke, what we really want to do predominantly is try and prevent pneumonia. So we know that there are various ways of trying to approach oral health care. We know that staff training and education in the stroke unit setting is not ideal, and this has been documented on many occasions. So on that basis, to move forward, we really need a clinical trial to try and evaluate the different approaches that we have. So on this basis, being guilty of using the abbreviations chosen is chlorhexidine or toothpaste, manual or powered brushing to prevent pneumonia complicating stroke. And this is a multi-center feasibility trial in the northwest of England. And the aim of this trial was to say, is a major phase 3 definitive trial feasible? So can we actually show that we could scale up and do a phase 3 trial? So it's worth pointing out at this stage that Chosen incorporated 3 main work streams. So one of them was patient and public involvement, which was led by Wendy Westerby, who many of you will know. There was the feasibility trial, which I'm going to report on today, and then there was a process evaluation. And this is a sort of qualitative implementation phase that looks at what worked or what didn't work and why. So Chosen, as I said, was undertaken at 4 stroke services in the northwest. So Fairfield, Salford, Wiston and Preston. So these were the objectives of the study. And I'm not going to read them all out, but I'll just give you a chance to just process and have a look at them. So these are objectives that we can then map onto quantifiable feasibility progression criteria. So with a flagship, well-designed feasibility trial that meets the NIHR framework, what you need are measurable feasibility criteria. And you can then say at the end of the trial, we met these feasibility criteria for X or Y, or we didn't. And you can then use the process evaluation to understand why you did or didn't meet them, and then what you might need to do next. So today I'm going to really talk specifically about the feasibility trial itself rather than the process evaluation, which is a separate talk. So today I can't really answer quite so much about Objective 4 or Objective 6, but I'll tell you a little bit about them as we're going along. So this is a sort of summary infographic which represents the trial design overall. So you can see that people who come to hospital with an acute stroke, aged more than 18, with dysphagia, and that could either be from failing the initial bedside swallow or an assessment by a speech and language therapist, or potentially both, within 24 hours of admission into the stroke unit, and with at least 1 natural tooth. So there's no good really brushing somebody's mouth out if they don't have any teeth. So people who were going to be repatriated, bear in mind the model in Greater Manchester, people who were imminently going to receive mechanical ventilation or end-of-life care, or at the time we did the trial, people with confirmed COVID infection were all excluded. So participating patients were randomized to one of 4 oral healthcare treatment groups. So initially randomized based on the brushing approach. So at the top we've got the powered brush, and at the bottom the manual brush. And then for each of those, they were then randomized further into receiving either chlorhexidine 1% gel or non-foaming toothpaste. Non-foaming, of course, to reduce the risk of aspiration. So brushing was for a maximum of 2 minutes or 30 seconds per quadrant of the mouth, depending on how many teeth the individual had. And those with dentures received a standardized study protocol whereby the dentures were scrubbed each night and stored in water overnight and worn wherever possible during the day. So the participants received this allocated oral healthcare treatment until the end of their stay in inpatient stroke services. So you'll see along the bottom there was the parallel PPI work stream, staff training and education, which I'll come on to in a minute, and the process evaluation. So what about the staff education and training? I'm sure many of you will be interested in this in particular. What we do know is that there is no standardized training, and the training that is given across stroke units in the UK is very heterogeneous. So we based our staff education and training on a previous pilot that I did in, I think, 2017, just at Salford, and this was an interdisciplinary education program that was developed for this type of a trial. So the backbone of it was a online training resource that you can see in the middle, and this comprised instructional videos mainly around how to actually do oral healthcare in terms of the different allocated treatments, but also some facts and information which was in a PowerPoint format. And the platform that this was on was secure. It can only be accessed from the hospital setting. We didn't expect staff to have to do this at home. And it was password protected so that the ward managers could get an understanding of how many of the staff had actually done it. And at the end, they had to do mandatory competency assessments as well. So alongside that, we also developed a shortened version called the Chosen Light training. And this was a series of laminated sheets summarizing some of the components. And these were available on the stroke units in a folder with a QR code where individuals could then access the online training. And all of that was supplemented by 6 to 10 individuals who volunteered from each service, so not each ward, but each service, to receive additional training from the dental healthcare professional who was a dental hygienist that was working with us on the study. And this face-to-face training was really to create oral healthcare champions who could deliver additional supervision and support for the staff for the oral healthcare treatments. And we did this before the actual main trial was implemented and started, and we ran it all the way through the actual duration of the trial as well, being mindful of the turnover of staff on the wards. So this slide just really shows you an overview of the time points at which we assessed the participants and the measures that we used. So participants were obviously assessed at study entry, 7 to 10 days after randomization, then weekly in terms of their swallow and nutrition status, serious adverse events and development of pneumonia, and then at discharge, and then finally at 3 months. So just to qualify some of these outcome measures or things that we were assessing, NIHSS score is probably familiar to many of you. This is a bedside measure of stroke severity. Throat is the holistic, reliable oral assessment tool, and this was developed at UCLAN as a nursing assessment index for oral health status in the general medical and stroke setting. And then GO-HIGH is the general oral health assessment index, and this is kind of oral health quality of life type of assessment as well. So importantly, on the basis of the objectives and these data collection, we formulated a priori various feasibility criteria that were quantitative, supplemented by the process evaluation, that were measurable against red, amber, green criteria that enabled us to say whether we could progress to the next stage of a trial. So what I'm going to do now is just run through the main results of the trial based on the objectives and how they were aligned with the feasibility criteria. So the first one was about recruitment and setup of the participating sites. So you will cast your mind back and see that when we're talking about late 2021, things were very different in healthcare. We've all got short memories, but we were in the midst of an absolute whirlwind of resurgence of COVID and also intense winter pressures, even compared to previous years. Despite this, we managed to get all 4 of the sites set up with sufficient numbers of staff trained to be able to get the green light within a 4-month period. So this shows the study flowchart, which is a fairly standard way of describing the flow of participants. So across the 4 sites, the research nurses and teams screened between January 22 and the end of January 23, 626 patients with suspected acute stroke. So of those, 148, which is about 23%, were eligible. And of the 132 that were approached, bearing in mind that not all sites have 7-day recruitment, 24% declined participation, which is about average for many clinical trials. So you can see if you follow down that CH-MAN, CH-POW, TP-MAN, and TP-POW were the different treatment allocations, and the participants were randomized pretty equally between the 4 groups. And at the 3-month period, 89 of the 101 consented individuals had completed follow-up. So we met the red, amber, green criteria, both in terms of agreement to participate and also in terms of completing follow-up. So this is the patient recruitment graph, and the dotted line shows that the target estimated recruitment rate over time. And the target we set fairly empirically was 120 patients across the 4 sites. And in feasibility trials, you don't tend to have a particular number of participants for your sample because the statistics are not designed for hypothesis testing. So you tend to come up with a number off the back of a cigarette packet that seems achievable based on the context of the trial. So we said 120, and you can see right from the beginning the graph diverges, and this was because when we started recruiting participants in winter of 21 into the new year of 22, we hit that really bad period with a new Omicron wave, lots of staff redeployment on the research side, staff sickness, and lots of delays in the stroke pathway in terms of getting people to the stroke unit within 24 hours. So we struggled to get back from that, but we did, as you can see, recruit consistently beyond that. And if you look at the red, amber, green criteria, we were right on the cusp of amber and green. So green would have been at least 102, so we were 1 away. So with these red, amber, green criteria, we are allowed to have some wiggle room and discuss with the trial steering committee, and it was felt that under the circumstances, this level of feasibility was an achievement in terms of progression criteria. So these are the characteristics of the participating patients in general. This is the whole 101 stroke patients that were recruited. And you can see a few things from here. Really, the majority were men, which again is fairly standard practice for clinical trials. That could be a discussion point maybe. The majority, of course, were ischemic stroke, reflecting the actual incidence in real life. And you can see that these patients were of moderate stroke severity, so the average NIH was 10, which again is to be expected because all of these patients are dysphagic. So the number of teeth on average per participant was 18, and as adults we have 32 teeth. So this gives you a picture of how bad dentition is in this sample of individuals, and nearly a third of them had dentures, this is higher than the proportion that you would expect without stroke. So when we stratify these baseline characteristics based on the 4 treatment allocation groups, there were no differences, they were well matched. So an important criteria is adherence to allocated treatment. So if you've got things that you're testing for feasibility, if the actual patients or the target population don't want to actually have what they're being given, then that's an important feasibility criteria. So overall, in all of the instances where the allocated oral healthcare treatment was prescribed, it was received in 91% of occasions, which is quite an achievement really. You can see that early on in the 7-day period, adherence was lower. This is probably because these patients were generally more unwell in the acute phase of stroke than they were a bit later on. And importantly, between the different treatment allocations, there was no difference really, only small numbers, but no difference really in adherence. And there wasn't across sites either. So the main reasons for non-adherence were patients actually declining without giving any particular reason, just as a one-off or, here and there. And other than that, clinical teams feeling that it wasn't appropriate on a particular day or occasion, patients being asleep, patients being off the ward, and so on. So what about safety? And you might say, well, come on, this is just brushing people's teeth. But actually, if you brush people's teeth very, very aggressively in the acute phase of stroke when they're dysphagic, then actually you might make things worse by creating lots of debris that they then aspirate. So this is really important. And in particular, we and the PPI group were a bit concerned about powered brushing because it's so aggressive at disrupting plaque and bioburden. So there were 19 serious adverse events in 16 people. And about a quarter of these were development of pneumonia, which is probably what you'd expect. And more like 40% was development of serious infections in general. So overall, again, in terms of the serious adverse events, no differences between the different treatment groups and no differences between the sites. So there was no safety concerns. So what about collection of outcome measures? So in a feasibility trial, you would generally have rather a lot or an excess of outcome measures, certainly with a complex intervention. And the idea of that is that you can then gather feasibility data, work with your PPI group beyond that to actually then see which outcome measures are really going to be worthwhile for a phase 3 trial. So this is just some of the selected outcome measures. An overall collection of the outcome measures was good or satisfactory. You can see the modified Rankin scale was very well collected. This is probably because the clinical teams and the research nurses are familiar with the modified Rankin scale. You can see that at discharge, collection of outcome measures was probably less good. Bear in mind, in reality, discharge from the stroke unit can be actually quite unpredictable. Without very much warning, to be able to then inform the research nurses. It can happen at weekends and it can happen out of hours. So maybe collecting data at discharge is perhaps less useful. And oddly, collection of the EQ5-5L, which is quality of life measure, which is very frequently used in trials, was not really very well collected at all. And it'll be important for the process evaluation to try and understand why some of these outcome measures were not collected as well and what the implications might be. So I'm going to emphasize that we have some exploratory secondary outcomes. So these are outcome measures that were just exploratory. And the reason for this is because the trial was not big enough and it wasn't powered and it wasn't designed to pick up differences in clinical outcomes. We didn't set out to do that. That would be the role of a definitive phase 3 trial. However, we were able to collect a modified Rankin, as you saw, and these two stacked bar chart figures show the distribution of modified Rankin for each of the 4 treatment allocation groups for discharge and 3 months. So you've got 0, 1, 2, 3 through to 6. And again, bearing in mind this is exploratory, the numbers are quite small, there are no significant differences in modified Rankin scale distribution, either at discharge or 3 months, between the treatment groups. What about pneumonia? Obviously, the whole idea here is that we're trying to prevent pneumonia. Interestingly, we didn't have a usual care group. This is something that we realized afterwards. So the fact that people were getting training for the unit and a toothbrush and toothpaste at one end of the spectrum is actually potentially an awful lot better than they were getting normally. So we didn't actually have usual care. But you can see on the left-hand side, this is pneumonia in the acute phase up to the first 7 days. And then in the second one, it's pneumonia cumulatively to discharge. And again, there were no differences between the treatment groups, but this is purely exploratory. So the other secondary outcome measures, throat, go high, the quality of life measure, there were no real differences there either between the groups. And we haven't analysed length of stay or discharge destination, but again, this will be only exploratory. So in summary, using primarily the predetermined quantitative progression criteria chosen did meet all of the feasibility criteria. So this is a very, very strong argument, along with the fact that there were no safety concerns, to proceed to a phase 3 trial. The fact that there were no differences in any outcomes between allocated groups is interesting. It's probably just the fact that the trial is far too small to see any differences. It tells us that we don't need to drop any of the treatment groups. There's no reason to drop any of the treatment groups. None of them in particular stood out as being any better than the other or any worse. We will be getting further learning from the process evaluation, which will help us plan for the next steps. And we believe, at least anyway, that a definitive phase 3 multi-center trial is definitely required. So this is yet another example of me basking in the reflected glory of a large research team, which includes Wendy and Ian, who are our PPI representatives. And this is, you know, an achievement because this is such an interdisciplinary group. We have representation from stroke medicine, dental public health, special care dentistry, nursing, and so on, right across the board. And a number of people at the coalface level, at the participating sites, really did help to make this happen. So thank you very much.
Thank you very much, Craig. I must say, I think that was a wonderful overview of basically peek behind the curtain for research, because it's sometimes a bit, for the uninitiated, which I include myself, it's always a bit mystical of how research actually happens, and I think it's something which we could all get a bit more involved in. Does anyone have any questions for Craig? Peter, is there?
Because of the nature of training and the fact that, you know, once you're in awards, you affect everybody else, I'm interested you went for individual patient randomization rather than for a cluster trial using lots of hospitals.
Yes, thanks, Peter. That's a really good question. So I think statisticians would always argue that individual level randomization in trial is preferable, and that's what we did in this one. However, we are seriously considering in the phase 3 trial having a usual care group, and this will be units that have no training and just do what they normally do. And in some ways that's not very exciting for them as participating units, and this is always the problem. That would necessitate cluster randomization, because otherwise there would be contamination from the training. And in Marion Brady's Cochrane review of oral healthcare, actually, based on the fact that the quality of the trials and the data that was in there was very limited, what does seem to be important in terms of outcomes is actually staff training. So we can't forget that that underpins all of this. So I think we might then need to do a cluster randomized trial next.
But actually training is good, because things that cost nothing in the world that we live in, actually, if it is about upskilling people, then that's, I mean, these are kind of low-cost interventions, aren't they, potentially? But I think that's kind of good news, isn't it, I suppose, rather than some expensive treatment that is going to be quite difficult to get implemented. This is something we probably can do when we know the answer.
Yeah, I mean, I'd like to think so as well. And I think fundamentally we all just need to take a step back and remember that this is not something that, although it's always difficult because the staff are conflicted with priorities, and certain things like mouth care and maybe continence are never really high in the agenda list. Let's just be honest about that. So in our MDTs, do any of us talk about oral health care? Do we have the relevant clinicians within the MDT to be able to do that? And I suspect the answer to that is probably no. I would say we're not asking people to do something really different. We're asking them to do what we think we should be doing, but maybe differently, with some structure and standardization, and with the opportunity to actually evaluate the tools in a robust and rigorous way. It's interesting that there are health economic angles to this, because, for example, if we did a definitive phase 3 trial and it became apparent that chlorhexidine and powered brushing were streets ahead in terms of preventing pneumonia, this would then pose a major problem with cost. So we would have to do, built into this health economic analysis. As you know, if you go to Boots to buy a powered brush, you can be paying anything for this really, and even through NHS procurement, powered brushes are very, very expensive compared to manual brushes. You can buy a bag of manual brushes for like, you know, £1 and get 50 or something, and that isn't the case. So yes, it's something that we should all be doing. Liz Lightbody from UCLan led on all of the process evaluation, and we have qualitative data on participants, their families, and staff that were trained and involved in the trial, and this is obviously also really powerful. And training was the most difficult thing to do. So the plan initially was to say, we'll go on to each unit and we'll train all of the staff, train all of them. And we thought we were being clever because we didn't think about classroom-based training, because that was never going to work in a million years. And actually, it was really, really difficult to get the staff even to respond to emails and open up the online platform and sign in. And we got lots of discussions with all the ward managers. Can you allocate 2 members of staff, at some point during the shift so they can do, the training was an hour in total. So again, we're mindful of all of this, and it was so hard because there was always somebody hadn't turned up. It was really busy in A&E, or there was one-to-one that was needed, or whatever. So it was really difficult. So I'm afraid to say that the training element for phase 3 is going to be a big challenge. So I think simplifying the training as much as we can, and getting real on-the-ground level buy-in from all of the units is going to be absolutely critical. So the units that are going to make this succeed are going to be the units that are really passionate about mouth care and they will want to bring this in. They will want to train the staff and embed some of these, skills and knowledge.
Thank you very much, Chris.